Good morning. I think we can start. Yeah.
Good morning, sir. I'm starting. Sir, a 49-year-old gentleman, farmer by occupation, resident of Pauta, came to our hospital with complaints of difficulty in swallowing for 9 months. The patient was apparently normal 9 months back when he gives alleged history of consumption of around 100 ml of liquid toilet cleaner on 4th June 2023 with the intent to commit suicide under the influence of alcohol. Immediately following consumption of corrosive, he developed odynophagia, throat pain, drooling of saliva, hoarseness of voice, and cough. However, there is no history of respiratory distress, chest pain, abdominal pain, stridor, and hematemesis. For the following complaint, patient was taken to a nearby local hospital where an Ryle's tube insertion was tried to induce vomiting but failed. Patient was then shifted to ICU. ICU stay lasted for 1 day, following which he was managed in wards. An endoscopy was performed immediately after admission on second day but was unsuccessful. The documents are not available for them. On fifth day, a contrast study was performed, following which patient had an respiratory discomfort and was shifted to ICU and later referred to our hospital. On 8th day, an HRCT was performed. Feeding jejunostomy was done on 15th of June, that is on 11th day, and feeds were started after 2 days. We discharged patient after 2 weeks, at which patient was able to swallow saliva and liquids with Takeda grade 4. He was taking and tolerating 2.5 to 3 liters of FJ feed daily. Post discharge, patient was lost to follow up. 2 months later, he returned to our hospital with complaints of progressive dysphagia, was able to swallow only saliva this time, Takeda grade 5, and approximately 4 to 5 kg of weight loss. He gives history of food getting stuck in the throat, hoarseness of voice improved over this time. Patient underwent an endoscopy approximately 10 weeks later without dilatation. Patient was explained about FJ feed and regular follow-up and discharge. He underwent barium swallow on 12th of January 2024, that is approximately 7 months later to the incident. Meanwhile, patient went to some other hospital and underwent another endoscopy approximately 8 months later after the incident without dilatation, following which he returned to a hospital for further management. At present, there is no history of odynophagia. There is no history of colicky abdominal pain, abdominal distension, ball rolling sensation of ballogamy. There is no history of hematemesis or melena. He has regained his lost weight in meantime. He has underwent multiple radiological investigations in between. He does not have any psychiatric illness or any previous history of suicidal tendency. Patient is able to perform all routine activity but not any strenuous activity. Patient is a known hypertensive. He was taking AMLO 80, which after the incident he is currently is not taking. There is no history of diabetes mellitus, tuberculosis, or thyroid disorders. Patient consumes predominantly vegetarian diet, approximately 2.5 to 3 liters per day through the FJ. Sleep is good. Bowel and bladder habits are regular. He was a known alcoholic for known years. He used to consume 3 to 4 days per week, approximately 90 ml of country liquor, which he stopped consuming after the incident. He was a known smoker and gutka chewer, which he stopped after the incident. Coming to my summary, my patient is a 49-year-old male, known hypertensive with no psychiatric illness, presented with alleged history of consuming 100 ml of liquid toilet cleaner 9 months ago with a suicidal intent. He immediately developed throat pain, odynophagia, drooling of saliva, hoarseness of voice, and cough, for which he was hospitalized for 2 weeks with ICU stay of 1 day without any respiratory support, during which he underwent an unsuccessful endoscopy attempt and feeding jejunostomy. Following discharge, the dysphagia persisted and progressed from Takeda grade 4 to 5. He has underwent 2 endoscopic further attempts without any dilatation and multiple radiological investigations in between. The probable diagnosis, it's a corrosive esophageal stricture that the patient has developed.
Okay, so in such cases, diagnosis is usually not a problem. Let's go back to the history. See, just as I say in cholecystectomy bile duct injury, here also I think it is better
Okay,
and
so in
safer.
such cases, diagnosis is usually not a problem. Let's go back to the history complaints.
Yes, sir.
See, just as I say, I think it is better and safer. Not a problem. Let's go back to the first slide.
What did they do wrong in this case?
Uh, Sir, first of all, when he went to the first hospital, to the nearby hospital, uh, they tried for an Ryle's tube insertion, which they failed so as to induce and vomiting.
Will it be done?
Sir, there are two schools of thought, sir, on this. Ideally, it should not be done because it can increase the grade of injury. It can lead to even perforation. But if it is tried, it should be only tried with most gentle under endoscopic guidance only. It can be put, sir.
They usually swallow a thread. You don't put a Riles tube. The other question is, what
Yes.
else did they do wrong? Was endoscopy so early in the course next day after the incident? Is that correct?
Sir, endoscopy they tried, sir. Actually, patient is giving history, is not having documents for it. He's just telling that they took me for endoscopy, but they told that ye kar nahi paye. They were not able to perform.
And what is your opinion about neutralization of the corrosive agent?
No, sir. Ideally, the neutralization of corrosive agent should not be done because it can lead to an exothermic reaction and it can further progress the grade of injury.
Okay.
So what I was saying, just as I say in post-cholecystectomy bile duct injury, here also go to your first slide, the presenting complaints.
Yes, sir. So this is my first slide, sir, of presenting complaint.
No, even before this.
This was the chief complaint.
This one, the chief complaint. So here, if some examiners stop you at this stage, and if we don't mention the corrosive intake, then the discussion can go in the direction of achalasia and malignancy and all that. So I personally suggest that it is better to say that difficulty in swallowing following suicidal or accidental intake of a corrosive liquid for 9 months or 9 months ago, so that from the first instance it is clear as to what we are dealing with. Otherwise, it can generate unnecessary discussion. Next.
Okay, sir.
What else should they have done which has not been done in this case, keeping his suicidal intent in mind?
Sir, they should have also taken a psychiatric opinion also, sir.
And started him on treatment, because second corrosive injuries, I have lost a patient after colon bypass. Patient had a second corrosive injection and died. So it's very important to realize that psychological management of a corrosive injury patient is critical. As such, with the corrosive injury itself, depression will be severe. And on top of that, if it's suicidal intent due to depression, more than likely that they'll try to commit suicide again.
So what do these symptoms suggest? You say immediately following consumption, he developed odynophagia, throat pain and all that. What does it suggest?
Sir, it signifies, sir, there is an oropharyngeal injury. Apart from that, it is a high-grade injury, sir.
Yeah, so these symptoms indicate that the injury, even in the esophagus, is likely to be at a very high level, cervical, and even the pharynx may be involved. And these are the patients who are more likely to have a upper airway injury also. What is your opinion about the role and place of endoscopy in the acute setting?
Sir, in the acute phase, sir, it should be ideally done within first 72 hours, likely after 24 hours and within 72 hours. Because sometimes if it is done within 24 hours, the injury can be, the grading of injury can be degraded, sir. Like it can be only an arrhythmia which can further progress. And after 72 hours, ideally it should be avoided for at least 3 weeks. Because the mucosa in that time, the wall is very friable and it can further lead to perforation chances are more.
So first question is whether it should be done. So you said that it should be done in all cases.
Yes, sir.
Why?
Sir, so as to document the grade of injury, sir, and accordingly we can prognose the patient and we can further plan the management.
How does endoscopy decide the management?
Sir, there is a grading, sir, named as Zarkas grading, sir. When we do the endoscopy, we can grade the patient accordingly. Uh, uh, Depending upon the grading, sir, specifically grade 1 and 2, they can be observed for first 24 hours and they can be started oral diet also. But the more the higher grade is, sir, there is more chances that the patient will go into a stricture later on, and patient can need feeding jejunostomy accordingly.
So the answer is that the endoscopy assesses the grade of injury, and the grade of injury decides, number one, whether the patient needs to be hospitalized or not. Number two, whether the patient needs to be taken to the ICU or not. Number three, whether the patient should have a feeding jejunostomy or not, because of the likelihood of development of a stricture in the follow-up. So is this the only way to assess the grade of injury?
Sir, clinically also, sir, first of all, and also CT scan grading is also there, sir, by which, depending upon the thickness and inflammation around the esophagus, it can be also graded into 4 grades. Like if in them grade 1 is the normal wall thickness, it is less than 3 mm. And if it is more than 3 mm, but there is no periesophageal inflammation, it is graded as grade 2, and the interface is maintained. In grade 3, there is periesophageal inflammation, but the interface is still maintained. And grade 4, the interface is completely gone, or there can be a local complication also.
Is it only inflammation and interface? What are you looking for?
Sir, surrounding inflammation, the wall thickness and surrounding inflammation with the surrounding structures, with the trachea and perforation, localized perforation, or some localized
More than the wall thickness, is anything more important? Wall thickness is important. It is the ischemia. That is why it is, you should have said, contrast enhanced CT scan. So more and more groups are now relying on two things. One is the clinical status of the patient, symptoms, the chest findings, the metabolic status, ABG and other parameters, and a contrast enhanced CT. And they are trying to avoid endoscopy because of its invasive nature and because it can be associated with problems and complications. Now, the other question which Dr. Desai asked you about the placement of the Ryle's tube. You said that if at all it is to be placed, it should be placed under endoscopy guidance. Why place a Ryle's tube? Should it be placed? Should it not be placed?
Sir, there are two schools of thoughts in this, sir. If it has to, if it has to be placed, it should be placed under endoscopy guidance with senior consultant only. It can serve two purposes, sir. First, it can serve the purpose of feed, and second, it can give us a track for further dilatation for this.
Yeah. So again, there is no agreement whether a Ryle's tube should or should not be placed. But if it is placed, you are right that it serves these two purposes. Next slide. Can you go to the next, please?
Yes, sir.
What is your opinion about dilatation? When should it be started? Do you believe in early dilatation?
No, sir. Not in early phase, sir. At least 3 weeks minimum, it should be waited, sir.
3 weeks is also comes under early dilatation. It is 6 to 8 weeks or more than 3 months, which is late dilatation. Correct me if I'm wrong, sir.
No, I'm not sure. What about steroids?
Sir, steroids should not be given, sir, because as such, there are more complications. So ideally, it should not be given, sir.
Okay, go to the next. There was one slide which said something happened after endoscopy.
Sir, actually, they performed
Sorry, this
contrast
one.
study on fifth day.
No, fifth day contrast study followed by respiratory discomfort and shift to ICU. What does it mean?
Sir, probably, sir, they performed a contrast study and they used probably a gastrographin study, sir, which the patient aspirated. Ultimately, it lead to aspiration pneumonitis.
Yeah, so this again suggests that probably there is a very high injury. And at this stage, it is not a stricture, but it is inflammatory edema, which is causing obstruction. And therefore, because there is history of throat pain and drooling, probably the patient aspirated and it caused respiratory distress. So you said probably they use gastrographin. So what should be used? Normally we use gastrographin for contrast study.
Sir, ideally, contrast study in the initial phase, it should be avoided, sir, because it can both, even a water soluble contrast like gastrographin, if it gets aspirated, it can lead to aspiration pneumonitis. And if we are doing with a barium, and if there is an perforation, it can leak into the mediastinum and it can lead to mediastinitis. So in acute phase, ideally, it should be avoided.
So the answer is
You
that in
should
the
use
acute phase, there is
non-ionic
too much
contrast.
So what is the indication for feeding gastrostomy?
Sir, if it is a high grade injury, sir, and at the initial setup, Ryle's tube Ryle's tube was not inserted. In those cases, when we suspect a prolonged course, patient cannot have food intake. In those, feeding jejunostomy should be done, sir, so as to preserve the patient.
Why not feeding gastrostomy if the stomach is normal?
Sir, stomach in future can be used for a conduit. So it's better to avoid feeding gastrostomy and to prefer a feeding jejunostomy.
So feeding gastrostomy, does it preclude the use of stomach? You can always dismantle it and still use.
Sir, as also this case in India also, sir, and this case as such, the more common it is acid intake, sir, which mostly affects stomach also, sir. So
But I said that if the stomach is normal,
yes,
would
sir.
you do feeding the gastrostomy instead of feeding jejunostomy? It's little more physiological.
Would prefer feeding jejunostomy, sir. Mostly this is what we also follow.
What happens to the reflex mechanism in corrosive injury? That's what sir is trying to ask you. Anti-reflex mechanisms in the esophagus. What happens in corrosive injury?
Sir, they are hampered, sir, and they're
How?
sir, because of the inflammation near the GE junction, sir, there can be an stricture. There can be pull up of the abdominal part of the esophagus, sir, and the loss. There can be loss to prevent the reflux, the normal mechanism, and it can increase the reflux chances.
That is one of the reasons you wouldn't give a gastrostomy feed. But like sir says, if the stomach is normal, gastrostomy is preferable because you can give high osmolar feeds, as versus a jejunostomy where you would have to give a isoosmolar feed, and it makes feeding that much more expensive and that much more difficult for the patient to give. Gastrostomy, you can give regular food pureed in a mixie, and you can actually maintain the calories better. Some people are reluctant to leave a suture line in the mediastinum. That's why they don't do a feeding gastrostomy. But that's not really the case.
Yeah, so these are very soft points because if you place the gastrostomy in the mid body of the stomach, you can always dismantle it and close the opening and still use the stomach. But yes, I agree that most people do a feeding jejunostomy for two reasons. One, especially if you don't know what was the nature of the corrosive and you have not been able to assess the condition of the stomach, whether the stomach is going to be involved in the corrosive process, whether there is going to develop a pyloric obstruction, because in that case, the gastrostomy would not or cannot be used for feeding. So yes, in clinical practice, most people or almost everybody would probably be doing a feeding jejunostomy only. Next, please. Okay, let's carry on. Yeah. I think that's all I wanted to say on the history. Let's go on further. Let's go to the management, definitive management.
Should I go to examiners?
Yes, yes.
Okay, sir.
What is the importance of hematemesis or melena? You did mention somewhere.
Sir, uh, because the stomach also can be involved, sir. In that cases, if the mucosa sloughs off and the progression of the grade happens, in those cases, patient can have a hematemesis or a melena, sir.
Yeah, so the answer is that presence of hematemesis or melena suggests a gastric injury more likely, but it can happen with esophageal injury also. Suppose there is severe esophageal injury and there is a sloughing of the entire mucosa over a great length of the esophagus, you could have hematemesis or melena, but by and large, it is more likely suggestive of a gastric injury. So it indicates both the site as well as the severity.
Can you
Yeah.
tell us the endoscopic grading of corrosive injury?
Yes, sir. The endoscopic grading of corrosive injury is by the name of Zarga's grading, sir. It's graded from grade 0 to grade 4. Grade 0 is normal, sir. Grade 1, there is edema and there is edema of the wall, sir, and erythema. Grade 2 is divided into two, 2A and 2B. 2A is a circumscribed superficial, it can be ulceration, erosions, or exudates. Grade 2B is extensive or circumferential involvement with ulceration, edema, and erosions and exudates. Grade 3 is further divided into A and B. It can be focal necrosis or it can be diffuse or extensive necrosis. And grade 4 is perforation.
Okay.
Yeah.
Please
Yeah.
proceed.
Yes, sir. My patient is a middle-aged male, average build and nourished, conscious, cooperative, and well-oriented to time, place, and person. His height is 172 centimeter, weight is 61 kg, BMI is 20.6. His performance status is ECOG 1. There is no pallor-rectus lymph node clubbing. His pulse rate is 88 beats per minute. Respiratory is 12. BP is 130 by 78 mm of Hg. Saturation is 98 to 99% at room air. Breath holding time is of 28 seconds. Examination of oral cavity. Mouth opening is adequate. Tongue movement is normal. Tobacco stains over teeth is present. No dental caries or halitosis. No mucosal erosion or lesions. Erythema, edema, discoloration, ischar or ulcer or slough is present. Examination of neck. Essentially normal. No scar marks are seen. For abdomen.
Anything specific you should mention in the oral cavity, especially in a case like this where based on history we are suspecting that it's a very high injury?
Yes, sir. First, like mouth opening and also are there any active?
Whatever you have mentioned is fine. Anything else? You should mention about the soft palate, the uvula, the
The vallicular.
tonsillar folds. Because if there is any scarring there, that again is an indirect evidence that it's a very high injury and there is likely to be some problem with the respiratory tract also and the posterior wall of the pharynx.
Yes. Abdominal examination. The shape of abdomen is flat. Umbilicus is central, midline inverted. All quadrants move equally with respiration. Upper midline scar is seen healed with primary intention. Expansile impulse, cuff impulse is present over the scar. FJ is feeding jejunostomy is present in the left lumbar region. No other lump, sinus, or engorged veins are seen. Inguinal hernial orifice appears normal. Flanks not full. External genitalia normal. On palpation, abdomen is soft and non-tender. No local rise of temperature. A 3 into 2 centimeter defect is palpable in epigastric region over the upper midline scar with expansile cuff impulse positive. No mass or organomegaly. Hernial orifice appears normal. No renal anga tenderness. External genitalia is normal. On percussion, liver dural starts at the fifth intercostal space. Liver span is 12 centimeter in the right midclavicular line. Rest of the abdomen is resonant to percussion. There is no evidence of any free fluid. Auscultation, bowel sounds are normal. No brew is heard. Digital rectal examination is normal. On respiratory examination, on inspection, trachea is central. Bilateral chest movement is equal. On palpation, trachea is central in position. Bilateral chest movement is equal. Vocal parameters equal all over the areas. It is resonant to percuss all over the lung fields. Other systemic examination are normal. Sir, my final summary here, sir.
You didn't describe the auscultation findings in the chest. You stopped at percussion only. It's important.
Yes, It was normal, sir, in my case, sir.
Also, you need to have a psychiatric evaluation written down, depression score. You should give them a questionnaire. You should document it. You should make sure they are on antidepressants, parenteral antidepressants if you are not able to give orally or through the feeding jejunostomy. And another thing, he is a hypertensive. How is his pressure being maintained normally? Is he being given tablets through jejunostomy?
No, sir. As such, he is not taking, sir. But his regular BP monitoring is normal, sir. We are seeing it.
So he's not a hypertensive.
Sir, previously he was diagnosed and he was taking prior to this incident, sir. This is what he was telling. But post incident is not taking, and through FG also he is not taking. But his BP is maintained, sir.
Okay.
Coming to final summary, sir, after examination.
Yeah, let's proceed. What will you do now?
Yes, sir. Sir, first I would like to review all his clinically after evaluation of the patient, sir. I would like to review all the reports that he previously he has got. The
How does re-evaluating his first endoscopy help you? Does it matter now?
sir, actually the first endoscopy he doesn't have the documents, but the endoscopy reports which he has with him is approximately 10 weeks later, and one done after approximately 8 months later, sir. Those
So
endoscopic reports.
What I'm trying to say that what he has had multiple endoscopies. What is most important is the most recent endoscopy.
Yes,
The
sir.
endoscopy findings at the time of injury today probably would not help us. It is the most recent status of the stricture which is important.
Yes, sir.
Let's see.
So should I show the endoscopy, sir,
Yes,
latest one?
Yes, whatever we have, show. But what I'm saying that if the patient has multiple endoscopies, most important is the last endoscopy.
Okay, sir. So, this was the first endoscopic report which he has with him, sir. It was done approximately 10 weeks later, sir, which showed that hypopharynx is visualized with endoscope. Guide wire could not be negotiated after visualization of hypopharynx as there was cicatrization with obliteration of the lumen of the piriform fossa, sir. The latest endoscopy that
What does this indicate?
sir, this indicates, sir, it is the injury is has led to an stricture formation in the higher level, sir. In the oropharyngeal area, sir, has been involved, sir.
It's almost like a pharyngeal stricture.
Yes, sir. Yes. So the latest endoscopy with him, which I have, is this one, sir. It was done on 22nd of February, sir. In this also, there is hypopharynx visualized with the endoscope, pinpoint opening seen in the upper esophageal sphincter. Scope and guide wire could not be negotiated beyond in the esophagus, sir.
So anything else after seeing these two endoscopies and after what we have discussed, anything which is missing here?
How about the trachea and larynx? What is the report on the trachea and larynx?
Sir, actually,
in these cases, it is very important to have the airway endoscopic visualization also.
sir.
Has it been done at any stage, direct laryngoscopy?
No, sir. Laryngoscopy we did, sir. We did here when he came. I have the video for the patient. I would like to show you, sir. This was the video, sir, of direct laryngoscopy. I'll just show you, sir. As we can see, sir, here, first of all, the vocal cords are visible, sir. And we can see, if we see on a continuous movement, sir, the right vocal cord movement is hampered, sir, and the left vocal cord is compensating for the movement for the movement, sir. So, sorry, sir. Left side of the vocal cord movement is hampered, sir, and right side is compensating for the movement, sir, as we can see in the video. And as we go up, sir, as we go up here, sir.
But there is no scarring of the vocal cords?
Yes, sir. As such, there is no scarring visible, but the left side of the vocal cord movement is hampered, sir. And as we proceed, come up, sir, the right side of the piriform fossa, if you see, there are secretions there, and as such, it looks like normal here. But the left side of the piriform sinus, if we see, it seems to be completely without any secretion, and it seems to be cicatrized. The epiglottis is also visible here, sir.
Is the epiglottis mobile?
Sir, during swallowing phase, it becomes mobile.
Is it in prone hai kya?
Yeah, because it's very important.
Yes, sir.
It
Because
is
it's
done
very
in prone
important.
position.
A lot of things get scarred.
Yes, sir. During swallowing, it was mobile, sir. There.
Okay.
Yes.
No,
sir.
right and left, was it done in the prone position? Because can you point out which is right and which is left with your cursor?
Yes, sir. Just a minute, sir.
The,
I'll just do, sir. 1 minute, sir. This one is the right one, sir. Is it visible, sir?
So it is in prone.
Yes, sir. Yes, sir. And this one is the left one, sir.
Yeah.
Here we
So-
can see here secretions are there, but here no secretion is there. Here mucosa appears to be normal. Here it seems to be cicatrized, sir.
So you are saying epiglottis glossary is normal, movement is normal, vocal cords, there is no fibrotic scarring, only the movement of one of the vocal cords is impaired. So is it possible that there is no injury and that is something which was pre-existing? Because only movement being affected, mucosa normal, no fibrosis, no scarring is bit doesn't fit in.
Some of that it is not due to
Yeah,
corrosive ingestion.
because there should have been some changes in the mucosa, in the appearance, and some fibrotic scarring. Anyway, so what was the impression?
Sir, they just made an impression, sir. It's a high stricture with the involvement of the left piriform fossa with the pinpoint uh, uh, pinpoint opening at the upper esophageal sphincter and left which through which the guide wire it was not negotiable, and here the left side of the vocal cord is not completely functional. The right side is overcompensating.
Okay, let's see the other investigations.
What is the importance of the piriform fossa surgically? Why is it so important? Sir has been emphasizing, we are emphasizing, even the report they are emphasizing.
Sir, in case of high pharyngeal strictures, sir, if piriform fossa is normal and healthy, sir, first of all, if we attempt an conduit anastomosis, sir, that length we can get. Second thing is this: if the piriform fossa is healthy, sir, it ultimately promotes swallowing, better swallowing for the patient. And second, patient can have high chances of aspiration can be there. A patient can need a permanent tracheostomy also in those cases, sir.
So you don't believe in pharyngocolostomy?
Pardon, sir?
Do you believe in pharyngocolostomy?
I believe, sir.
So why do you think aspiration will be there? Epiglottis is mobile, vocal cords are mobile, and the left vocal cord is compensating for the right palsy. Right palsy could be a congenital palsy that could be there because it's a bit difficult to explain with corrosive injury. So pharyngocolostomy can still be done.
Yes, sir.
What are the contraindications for dilatation?
Sir, it was a very pinpoint, sir. They were not even able to pass the.
Not in this case, in general, theoretical question.
Sir, first of all, sir, it should ideally be not tried within first 3 weeks or in acute phase. High grade injury, higher level of injury, sir. It should be avoided, sir.
There are two schools of thought here. There are people who believe in early endoscopy and steroids, saying that dilatation is possible and it's easy. It's possible to maintain.
Less like
Yes, sir. I'm.
Yeah, next slide.
a very tight stricture, very long strictures, multiple strictures. These are difficult to dilate and they will not have a good outcome.
Yes.
High stricture, I'm not sure because high stricture, even surgical, is technically difficult, both in terms of technique as well as the outcome.
Yes, sir. Yes, a long stricture, sir, length more than 10 centimeter. Number of more strictures, sir, 3 or more. These strictures are they are difficult to dilate, sir.
Abdominal esophageal stricture also is difficult to dilate.
Yes,
because the axis is not always preserved.
Yes, sir. Yes, sir. Sir, this is a contrast in the city, sir. It was done outside. Here, if we see the images, sir, as such, here, if you see, sir, the images, sir, this is the level of the piriform fossa, sir. Here is the trachea. And this is the right piriform fossa, which is there, but the left is here it is cicatrized. If we go down, sir, these are the areas of vocal cord. If we further go down, sir, here we can see esophageal lumen, sir, here, this place. But it, as such, no lumen can be visualized in the visible part of the esophagus throughout the city's axial cuts till here. And in another
Was oral contrast given in this CT?
no, sir.
So then it will be very difficult to visualize the lumen even if it is there. Esophagus normally is collapsed.
Yes, sir. Yes, sir.
But at some stage it was mentioned that oral, not in the CT, that oral contrast was given and he aspirated. That was a different study.
Yes, sir. That was the initial first, the barium swallow they did, sir, at the initial time, that time. Here further, sir, here, if we look here, sir, here the stomach wall appears to be thickened and the size of the stomach appears to be reduced. The cicatrized stomach here as such is visible, sir. And in the sagittal cut, sir, if we see, here again the trachea is visible. Here also the trachea is small place. The esophagus as such, lumen is totally cicatrized. It is not visible, sir.
No,
Here.
but question, that is the question, that if you don't give oral contrast, suppose you do a plain CT of the chest, would you see the esophageal lumen even in a normal person?
No, sir.
Normally,
No, sir.
esophagus is collapsed, there is no air there. So you
Yes,
would not see it. So if you have not given oral contrast, how can you say that there is cicatrization?
Yes, sir. Yes. Only, sir, because there was pinpoint stricture and prior aspiration. They did
That is
not.
on endoscopy.
Yes, sir.
That
Yes,
is
sir.
on
But
endoscopy.
oral contrast should be given, sir, to comment on that.
I'm not sure whether an air contrast study has been described, that you ask the patient to swallow a lot of air and then see. I'm not sure, because you can see the air in the oral cavity.
Yes. These were the reports, sir, for respective. And one barium swallow was also
What is the
performed.
radiologist's impression on CT?
Sir, for the neck, they told that there is diffuse irregular mucosal thickening noted in the oropharynx and upper esophagus. Rest, everything they have commented to be normal, sir. And on thorax also, they have commented everything to be normal, sir.
And you must, whenever you are looking at the chest in these cases, you must always make a comment on the lung, that whether there is any evidence of aspiration pneumonitis or any evidence of a fistula. Okay, let's see the oral contrast study.
1 minute, sir. This was the barium swallow that they performed, sir. As such, in this also, no esophageal lumen as such is visible, but the contrast has gone into the tracheobronchial tree, and we are able.
Was it done under imaging guidance?
Sir, actually, this he got it done from outside, sir.
Yeah, the reason I'm asking is, if you do it under imaging guidance, you can differentiate between tracheoesophageal fistula and aspiration. Otherwise, you can't differentiate the two.
We don't have any record for that. Only the report was available with him with this, and
So
the report.
what else does it show? Go back.
Yes, sir. Yes, sir.
It shows contrast in the tracheobronchial tree, which, as Dr. Desai said, on a static film, you cannot say whether it is aspiration or a fistula. It can be either. What else do we see? Part which is being visualized with the contrast.
Sir, the upper, just above the cricopharyngeal region, sir, there seems to be a little narrowing, sir, there.
What is the difference between right and left? See the first cut, the first part. See the difference between right and left?
Cicatrize the right.
Yeah, the right piriform fossa is much smaller than the left is almost normal. Do you see that?
Sir, this one, sir. Yes, sir.
Yeah, the outpouching.
Yes, sir.
Compare the left and right. Left looks apparently all right, but right is much smaller and altered shape also. So same findings which we saw on the direct laryngoscopy.
Yes, sir.
So
Yes,
Rajen, this would classify as a pharyngeal stricture, isn't it?
Yes, sir. That would be a pharyngeal stricture. Or you could say high esophageal stricture. Cricopharyngeal stricture is a better term.
But
Pharyngeal
piriform
stricture,
fossa is
usually posterior
involved.
wall of pharynx is,
No, I'm
if
saying
posterior wall of the
piriform
pharynx
fossa
is
is
involved,
involved.
they call it a pharyngeal stricture. Under which circumstance you won't be able to see the vocal cord.
I thought that this is the right piriform fossa,
Yes.
this is left piriform
लेकिन right को
fossa.
next वाले में देखेंगे तो it is not.
हाँ, yes, but the shape is altered. Size is also not the same as the left. So what I'm saying, if the piriform fossa is involved,
Yes, sir.
piriform fossa is a part of the pharynx.
Yes, sir.
So then, semantically speaking, it becomes a
Hypopharynx.
pharyngeal stricture because now the anastomosis will have to be above or cranial to the level of the piriform fossa, where the piriform
Yeah.
fossa scarring is there. So it will be a true.
Actually, on the posterior wall, sir.
In laryngoscopy, which piriform fossa was scarred? You said right, na?
It was no, sir. Left one was scarred, sir. Right one was having the secretion and
I
all.
don't think so.
Should I show the video again, sir?
Because in this, the right looks abnormal to me.
Sir, just 1 minute, sir.
Has the radiologist commented on piriform fossa in this barium?
No, sir. They have not commented, sir. Sir, here it will show, sir. I'll just show you again. Here, if we see, sir, this one is the right one, sir, and this one is the left one, sir.
Okay, so we have only 5 minutes left. So going back to the question which in between Dr. Desai asked, that if it is such a high, almost a cervical esophagus, cricopharyngeal, or even a pharyngeal stricture,
Yes,
where
sir.
you think you will end up doing almost a pharyngoconduit anastomosis.
Yes,
What are
sir.
the problems associated with it, and what precautions you take?
Sir, with high anastomosis, first thing, the conduit that we will take, sir, we have to ensure that the vascularity is good at the tip, first of all, so
That
that
is true for high or low, anything. Now I'm
Yes,
asking specifically for a high anastomosis. What are
Yes,
your
sir.
worries? What are the precautions?
Sir, one thing, sir, patient can have a regular aspiration for which tracheostomy will be required. Second, the swallowing reflex that is there, sir. The patient has to learn a proper swallowing technique in them so they can adapt gradually. Otherwise, it can lead to an aspiration. A patient can need a permanent, permanent tracheostomy will be required, sir.
Yeah. So the answer is that other than being a technically difficult anastomosis because of the access, because of the length of the conduit required, the problems are that the patient will not be immediately able to swallow well.
Yes, sir.
Because the swallowing mechanism is disturbed. Second, in the initial stages, there is bound to be aspiration. So that is why in a case like this, I'm sure every surgeon would do a tracheostomy. Now, whether that tracheostomy is going to become permanent, you cannot predict. And that is why, as Dr. Chattopadhyay used to teach us, that you have to counsel. This is a situation where counseling is very, very important. And the patient has to know that there may be a situation where he or she may have to choose between the two options. Either he can swallow or he can speak. And in many of these cases, it may not be possible to have both the functions normal. So you have to mentally prepare the patient for a permanent tracheostomy. Most patients choose to have the swallowing function because even with tracheostomy, you can develop what is known as a what is it called?
Esophageal voice.
Sorry?
Esophageal voice.
Yes. With good counseling, they can kind of learn some
Esophageal phonation, it's
for routine, normal day-to-day communication. But counseling, preparedness for a permanent tracheostomy is very, very important. Although, as Dr. Desai pointed out, the positive thing here is that the epiglottis and the vocal cord compensation is good enough. So, but there is bound to be aspiration. Whether that aspiration will go into the respiratory tract or not, that the epiglottis and vocal cords will prevent. In a case like this, I'm sure all of us would at least do a temporary tracheostomy because you don't want problems in the early post-operative period.
So it is surprising that they do well actually. Despite not expecting it, they do well. Provided you make sure it's a well-vascularized conduit, which doesn't result in a stricture again. If you take it on the posterior pharyngeal wall, they are able to swallow. It has to be done just below the level of the epiglottis. If you do it above the level of the epiglottis, there are a lot of problems associated with it.
Any other point, Rajen? Kulbhushan is also there. Kulbhushan, anything you want to add?
No, sir. Thank you.
Thank you, sir.
Okay.